tract, the non-neoplastic that is, because there will be one lecture dedicated to cancer and LUT. Starting with the renal pelvis, the ureter, bladder, and urethra that is lined by a urothelium, by the urothelium, what used to be called actually the transitional epithelium. It is called that way, because of the fact that it has actually a special feature of, being thrown in folds. So this is really a very characteristic feature of the urothelium, and that will allow it for expansion when it receives the bolus of urine that is coming in, and will accommodate actually that incoming bolus of urine. In terms of thickness, it actually ranges in thickness from 2 to 3 in the pelvis, all the way to 3 to 7 layers in the bladder of this transitional epithelium. One thing you're going to find out here, this is a trichrome stain of the ureter. If this, this urothelium that is thrown in folds, surrounded by a dense lamina propria. The blue is collagen, and then finally 2 layers of muscle in the 2 upper thirds of the ureter that will be joined by a 3rd layer in the lower third of the ureter. Between the ureter and the bladder, there is no anatomic valve. Rather, there is actually what you call a functional valve. The functional valve is the reason, or the work of the oblique angle with which the ureter opens in the inferolateral posterior aspect of the bladder wall. That's number one. One of the reasons why you have a functional valve. The second one will be actually the 3rd layer of muscle in the lower third of the ureter that will add sturdiness to the urethral wall, so it will be harder actually to reflux into it. And the 3rd one is that actually when the ureter contracts, it will obliterate the urethral orifice and prevents the reflux into the lower ureter. Another actually what you call clinical application of the anatomical course of the ureter will be the points of narrowing. The first one, 3 points of narrowing. The first one is at the origin of the ureter, so at the uretero-pelvic junction. The second one as it actually crosses into the pelvis in front of the iliac vessel, and the 3rd one as it enters the ureter, the urinary bladder. Now, why is that important? Because in case there is a stone impact, these are the regions that they will look for in the X-ray and also by ultrasonography. All right, so this is pretty much it. One thing actually I may add is that the ureter has a retroperitoneal position. As a result of that, a lot of the processes that happen in the retroperitoneum is going to involve the ureter, as we will see. So some of the congenital abnormalities that we'll talk about, starting with the double ureter. What we call a true double ureter with 2 actually pelvises, or a bified pelvis with 2 ureters arising from it. Now there is also uretero-pelvic junction obstruction, which is the most common cause of hydronephrosis in infants and children, something important to know about. A diverticulum in the urethral wall is rare, but when it happens, it's usually asymptomatic, as you will see this is different from the diverticula that will happen in the urinary bladder wall. A hydroureter, similar to what you will be seeing actually. We have not seen it so far probably. You will see it in the GI tract. There is also something known as a megacolon or a hydrocolon, and there is also something known as a megaesophagus. In that case, you will see that congenitally, one of the congenital causes of the hydroureter will be actually the loss of the ganglion cells in that region, in that segment. So that is going to result in failure of the expansion of that segment to accommodate the incoming bolus of urine. As a result of that, this area is going to be narrowed and obstructed, and the patient will present with what's known as hydroureter. You see that also in the level of the esophagus, what's known with achalasia, and also in the colon with what is known as toxic megacolon. Or what's the other name for it? Toxic megacolon or Hirschsprung disease, if you ever heard that name before. All right, so inflammation, let's say actually there is a stasis of whatever sort, from impact of stone, from a tumor, maybe from prostatic, hyperplasia. That's going to result actually in, inflammation. That's going to result in inflammation in the urethral wall. And, that's going to be, marked by the accumulation of lymphocytes in the subepithelial region, in the lamina propria. This dense area will be roaming with lymphocytes. And those lymphocytes are going actually to cause it to aggregate into what you call pseudo follicles. So they will start actually to show up like bumps in the mucosa of the ureter, of the urothelium. At one point in time, these pseudo follicles are going to involve with the chronicity of the condition, with the chronic inflammation. They will involve. They will actually create a lumen, resulting in the formation of cysts that will rise above, the urothelium, and turning into what's known as urethritis cystica. Now there are causes, internal causes for urethral obstruction. Of course, stone is high on the list, the most common one. Structures, either congenital or acquired, could be also there. Any kind of inflammation that is going to happen in the ureter, that will be followed by healing. Usually the healing will be by fibrosis. That's going to result in in a stricture. With tumors, you see that the most common tumor is going to be the FEP, the fibroepithelial polyp, and also the urothelial cell carcinoma. Blood clots may actually be caused by a renal stone, a tumor, or papillary necrosis that may reach the ureter. Is the brightness of the screen okay, or is it dim?
Oh, it's good.
It's good?
Yes.
Can see it well?
Yes.
All right. Now, neurogenic interruptions, this is something that most likely you're going to be doing. Cutting actually the neural, supply to the ureter and preventing actually the bolus of urine from moving, because actually the movement of the ureter from the pelvis, when someone is standing up to the urinary bladder is not happening just by gravity, but by actually the neural impulse as well. That is going, the vagal neural impulse that's going to push it downwards towards the urinary bladder. Now there are extrinsic causes of urethral obstruction. Pregnancy is high on the list, and pregnancy, two causes for this. One of them is going to be the hormonal status, the hormonal stimulation that is going to result in muscle relaxation, and that's going to result in actually what we call a functional kind of obstruction, not a real obstruction, simply stasis. And later in the course of pregnancy, when the uterus becomes an abdominal organ and starts to impinge on the ureter itself. Any kind of periurethral inflammation and fibrosis. For example, there is one disease known as primary erythroperitoneal fibrosis. Ormond's disease. Ormond's disease is going to result in actually in the.
You want me to close the?
The mics are good.
Thank you very much. All right, so erythroperitoneal fibrosis. That was made famous actually by one of the drugs that were used to treat migraine. And it is an ergot alkaloid derivatives, known as methysergide, that caused actually erythroperitoneal fibrosis. So this is where actually the erythroperitoneal fibrosis became famous. And what happened actually, there is extensive fibrosis in the erythroperitoneal space that will entrap the ureter, resulting in its obstruction. Any kind actually of inflammation in and around the ureters may actually be involved, may extend to the ureter and involve it in the process of inflammation that will be followed by healing and fibrosis and strictures. Endometriosis, ectopic endometrium, as you know, if you probably you don't know, I'm not sure. Have you guys read anything about endometriosis before? So endometriosis is the presence of endometrial glands and stroma outside the uterus. And what happened, that could happen actually anywhere in the body. And those actually glands and stroma are going to cycle with the normal endometrium. But now this cycling is happening somewhere else outside the endometrium. And as opposed to what you expect to see in the endometrium, which is actually healing without any evidence of fibrosis, without any evidence of cell damage, the healing that happens outside the endometrium is going to be associated with fibrosis. That's actually one cause for the ureter to be closed, to be obstructed from without. Any tumor that arises in the vicinity of the ureter may actually again entrap this ureter as the tumor spreads, and that's going to be followed by obstruction. This includes tumors of the rectum, of the bladder itself, the prostate, ovaries, anywhere actually in the vicinity of these structures. Yes.
Is the retroperitoneal fibrosis, is it involving the ureters, or is it obstructing it from other organs?
No, it is itself actually involving the ureter. It entraps it, involves it, and obstructs it completely, bilaterally. Yeah. All right, so tumors, fibroepithelial polyp, most common, is always actually benign in every single organ in the body. Less so is the malignant, which is the most common tumor arising from the ureter, which is the urothelial carcinomas. We used to call it actually transitional cell. Now it's called, the proper name is urothelial carcinomas. Now coming to the urinary bladder. The urinary bladder is this viscous muscular organ that is lined by actually 3 layers of muscle. Now, one of the application of the anatomy, of the functional anatomy of this concept is the fact that actually those muscle layers do not completely overlap. So they leave, spaces, between them when, the urinary bladder wall, contracts to void the urine. And if there is any kind of increased pressure intracystically, that actually may be translated into herniation and diverticular formation. One of the things that we used to do when I was trained as a pathologist in the U.S. was to actually gross the urinary bladder wall. One of the things that you need to know is where the tumor is arising from. Is it upper, posterior, inferior? The apex, the trigon area, very important. As well, you need to actually look for any kind of adhesion in and around, the urinary bladder. You have to look actually for any kind of redness in the urothelium, which is a sign of carcinoma in situ. And in terms, actually, you have to look for any kinds of tumors. Usually, when it comes to tumors that arise in the urinary bladder, these are actually tumors similar to what you see in the aerodigestive tract, because it has what you call field effect. So the same carcinogen are going to be affecting the whole urothelium. So how many actually, what do you expect the number of tumors to be in that case?
A lot.
Usually multiple tumors simultaneously happening in the level of the urothelium, because the same carcinogen are affecting the whole thing. This is similarly seen actually in the digestive tract, in the GI tract, and also in the airway. All right, one of the clinical application of this is what you actually, when you learn basic science from a clinical point of view. So this is the urothelium, this is the mucosa right here, urothelium lamina propria. And then here you see what you call fine wisp, W-I-S-P, wisps of muscularis mucosa. Now the muscularis mucosa that may be seen has a clinical value. Why? Because you have to make sure that if there is a tumor dipping down and going into what looks like muscular tissue, you have to make sure that it is actually proper muscular tissue, proper muscular layer, and not muscularis mucosa. Why? Because muscularis mucosa, when it comes to invasion, it does not have any value. It's not more than the lamina propria invasion. But if it is in the muscularis propria, then that's going to take the stage of the tumor higher. So important, something to keep in mind. The other thing that you need to look at is actually the urothelium here. The most upper layer of the urothelium is, are cells that have very wide, upper aspect, if you will, and with a lot of cytoplasm, known as umbrella cells. Okay, so those cells, and they have very, tight junctional and adhesion proteins to make sure that none of this, urine that is accumulating at that site seeps in within the urothelium and into underlying tissue. Here's another, actually, a clinical application of basic anatomy and histology, or what is known as the von Braun's nest. Von Braun's nest, here you find actually another German name, and I told you always be worried about German names. Usually they are names that rattles, someone in the middle of a USMLE exam or a Canadian exam. So, when you look at these actually nests, for the untrained eye, it looks like actually what you call invasion of certain, epithelium into the lamina propria. But in reality, actually, these are invagination of the upper urothelium into the lamina propria. And the way to actually differentiate this between this and invasion is to look at the border of these nests, and you will see that these borders are very, sharp. Do you agree with that?
Yeah.
All right, so it's called cookie cutter border. Cookie cutter?
Yeah.
For anyone is interested in cooking, I'm going to ask the same question to the girls because none of them is interested in it. Anyone of you is interested in cooking? Good job, thank you. All right, so cookie cutter, the cookie cutter, right? The one that you use to create this, it's what you call a cookie cutter. So there are no infiltration borders here, right? Which is what you should see if it was malignant. Two, you look at the lamina propria and you will see that there is no response from the lamina propria, for the presence of those nests. So, and third one, if you go on higher power and you look at these cells, you will see what you call bland cells, normal cells, benign cells. Nothing really that will catch the eye in terms of dysplasia. All of those are signs that what you are dealing with is a benign entity. In this case, it's a von Braun's nest. Now, there is another clinical application for this, as we will see in the next few slides. Diverticula. So this is what I mentioned to you. Because of the fact that the urinary bladder, muscular wall, muscular layers are not completely overlapped, they leave spaces between them when the urinary bladder is going to contract against an obstruction. This obstruction, most of the time, the 99% of the time, is actually prostatic hypertrophy. Because of the fact that actually, there's those gaps within the muscle layers of the urinary bladder, you will see that herniation may happen, which is really the right way to think about, the acquired diverticulum that will happen in this case. In this case, you will see that the mucosa, which is the urothelium and the lamina propria, will go through these, area of gaps within the muscle layers, resulting in the formation of acquired diverticulum. So now there is what you call acquired diverticulum. In this case, if you take a section of this acquired diverticulum wall, you will see that it does not have any muscle layer, correct? Because it is simply the mucosa that has herniated. Whereas if you took a section of a congenital diverticulum, you will see that it retains, certain muscle layers in its wall. So this is the differentiating point between the two. Now, actually, in this case, you will see that it is more likely that the diverticulum is going to be actually, symptomatic than those that were found in the ureter. The reason for this is that it is larger. This is one. Two, stasis may happen in this case. That will open the door for infection, stone formation, and very rarely, a cancer development. Here's another congenital abnormality of the urinary bladder, which is a defect in the anterior urinary bladder wall, with or without defect in the abdominal wall, in the anterior abdominal wall. And if this is not actually caught up early and treated early, it will result in a metaplastic change of the urothelium that may actually go on, again, if it's not treated, into giving rise to adenocarcinoma. Another actually congenital anomalies is a patent urethus or patent urethus. In this case, this is a fistulous communication between the umbilicus and the urinary bladder that should close, at delivery, right? But in this case, it stays open. When it stays open, it will result in the introduction of bacteria into the bladder. So chronic infection may happen. Sometimes, it will close, but not completely, resulting in the formation of what is known as urachal cyst, as you can see here. The urachal cyst or the oracle cyst is one of the few locations where you see a development of villus adenoma, which may explain why it has actually a high incidence of development into adenocarcinoma of the urinary bladder, which is a pretty rare but pretty aggressive form of tumors in the urinary bladder wall. Now you will see that again, villus adenoma. Villus adenoma has a tendency to become cancerous, whether here in the urinary bladder, whether in the GI tract, in the colon, in the gastric, in the stomach. Anywhere you see villus adenoma, there is a chance that it may actually develop into cancer far more than other types of adenomas and polyps. All right, now acute cystitis. Acute cystitis, there are some risk factors for lower urinary tract infection. One of them is the female sex. The reason for this is the short urethra and the ascending infection. Ascending infection because of the fact it is in direct, in the direct neighborhood, between the genital and the urinary, the urethral orifice is, if you will, that is going to result in ease actually of entry of bacteria into the urethra and ascending into the urinary bladder. Another thing which is the most common cause actually of acute cystitis is something that you do in a hospital setting, and that is going to be instrumentation. If you actually introduce a Foley catheter and then you don't take it out, and as a result of that, it will be a harbinger of infection. Let's say 5-6 days. You should take it out very shortly after you put it in. If you don't take it out, it may result in urinary bladder infection. Not only this, it is the most common cause of sepsis, believe it or not, in hospitalized patients. Sexual intercourse, what's also known as honeymoon cystitis from the repeated trauma to the urethra. Diabetes mellitus for two reasons. One of them is going to be the hyperglycemic environment favored by bacteria, and secondly, by the blunted immune response that happens in diabetic patients. Cyclophosphamide is an anti-cellular therapy for malignant tumors, for a lot of malignant tumors. If it's taken regularly by the patient, you will see a side effect of its use known as hemorrhagic cystitis. If the patient continues using this over the long run, it may result in the development of urothelial or squamous cell carcinomas of the urinary bladder. Schistosoma hematobium is a parasitic kind of infection where you see that the eggs of the parasite are going to get embedded in the lamina propria, creating chronic infection, chronic inflammation from this chronic infection that is going to be there for a long time. Eventually, they may result in the development of squamous cell carcinoma in about 70% of the time, and urothelial cancer in about 30% of the time. Who's famous? Who died as a result? That's it. All right, asymptomatic bacteriuria in women. So what is the gold standard for that definition? Usually on a routine culture, because there are no symptoms. 2 successive cultures with 100,000 or more colony forming units per milliliter in an asymptomatic patient. What are the causes? Elderly women in nursing homes because of the neglect and the unsanitary conditions. Diabetes mellitus, we just talked about this. And importantly, most importantly, is pregnancy. Now, when pregnant female have asymptomatic bacteriuria, you, the treating doctor, is going to be in a bind, because there are very few medications that you can give actually for someone who's pregnant. But because it's the renal block, I need to ask you this. Let me tell you that you need to treat. Why do you need to treat? Someone who has no symptoms from a lower urinary tract infection in the urinary bladder, something that is so distal and should stay where it is, right? Why do you have to treat it?
You don't call it pyelonephritis.
Pyelonephritis, how does that happen? Ascending, right? So which is the most common root of this. So why would you care about pyelonephritis? Pyelonephritis could be treated as well, right?
It will cause
What are the chances actually of it becoming pyelonephritis?
I
think high.
Not so high. Actually, depending on the study you read, it goes between 8 and 50%. So this is significant, right, in half of the cases. Now, why would you treat someone, even, like, why would you care if someone has, ascending pyelonephritis?
Because pregnancy, I think, is also associated with.
Right, so there are pregnancy complications actually, there's obstetric complications, including the premature rupture of the membrane, including premature labor, including IUGR, intrauterine growth retardation. There's a long list of obstetric complications that will actually backfire on the pregnancy itself. So you, the good doctor, has to treat actually, and you have to choose something that is going to be, as benign as possible, as hard as this can be, when it comes to pregnancy. Sterile pyuria. In this case, you are seeing actually white blood cells. You're seeing segmented neutrophils, but without any bacteria or any kind of bug growing in the urine. The reason for this is either you have not chosen the right medium for the growth of the bacteria, or it could be related to something else other than an infection. For example, acute tubulointerstitial nephritis following the ingestion of some medication that will give rise to this condition. Here's an example of hemorrhagic cystitis. It's clear what you find here. The most common cause is going to be trauma, so something that you do to the patient in terms of instrumentation, overzealous instrumentation, if you will, and when you scope the patient. So infection could be with a viral infection, and drugs with cyclophosphamide. Another special form of cystitis, in this case a chronic form, known as interstitial cystitis. Your patient usually is a female who's presenting to you with an exquisite type of suprapubic pain that does not respond to any medication. All the investigations that you're going to be doing are going to be negative. The only thing that you're going to be able to elicit from her history is a connection to SLE. She was diagnosed, or she had a past history of systemic lupus erythematosus. So actually this disease is a form actually of the autoimmune disease, of the constellation of the autoimmune disease that the patient may be having. And when everything fails, everything that you have done when it comes to investigation of any kind of infection is going to be negative. You go ahead and scope the patient, and if you're lucky and careful, you will be seeing that there are actually a region that is a bump in the mucosa. When you take that lesion, depending on the chronicity of the case, either you're going to be finding, a transmural inflammation, non-specific inflammation if the case is recent, or actually transmural fibrosis if it is, a pretty old, an advanced, case. The end result is going to be that, there will be fibrosis in all the areas of the bladder wall. Here's another actually form of chronic cystitis, in this case with von Braun's nest. So you can see here that, the von Braun's nest that we have just talked about, all the features are here the same, are surrounded by this, intense inflammatory infiltrate. It is far more than normal. In every organ there is actually what you call a transient inflammatory infiltrate. In case it is on standby in case of an infection. But when you look at this with the trained eye, you can tell that there is far more than normal. Now you look at actually those von Braun's nest, and you will start to see that they have started to open a lumen. That's resulting from the chronic inflammation. That's a process known as involution. Eventually, involution is going to happen at the same time that metaplastic change is happening as well. The first thing is going to be cuboidal metaplasia, which does not have any connotation, any clinical connotation. And then, glandular metaplasia, as you can see here. How do you know it's glandular? How do you know it's glandular? Because I'm saying so, right? Good job. All right, but if you look at this, here's a couple of things that you need to look. What are these actually, where I'm pointing the arrow right here? And here. This is mucus. Intracellular mucus, how about that? Okay, that's one. Two, if you look at the cells, they are what we call a 3D cell. This is always glandular. Whereas actually squamous is always 2D. You can see, the 2 dimension of the squamous sheet. So this looks very much like a 3D structure. This is one. Two, look at the border. They are actually hugging each other. Right? This is like being in a big concert, when you are starting to, what do you call it? Snuggle on someone near you. You know, this is very much so. Right here, you can see that, right? So this is glandular metaplasia for sure. Now, why is that important? Why am I mentioning this to you? Because at one point in time, the cystitis cystica glandularis was known or was promoted as a possible preneoplastic condition. Now we know that this is not the case. The most recent edition of Robbins have decided that this is not the case. So, watch out for the next edition of Robbins. Maybe they are going to change their mind again. God knows. All right. So, but as it is now, it is not a preneoplastic condition. Look at this right here. Isn't that a beauty, man? So you can see right away that there is incredible amount of infiltration, right? All these cells are lymphocytes. And in addition to this, in addition to the lymphocytes, you see those von Braun's nest that not only undergone glandular metaplasia, but also intestinal metaplasia. And what are these cells as well? These holes, starting with a G, goblet cell, and a goblet cell metaplasia. So here's a question for you that I asked that girl as well. If you tell it to me, if you give me the reason for that, me and you are going to have actually our secret talk about one exam question. Don't say that to anybody, and I hope you're not recording this. So my point is this: how come that actually something that you usually find in the GI tract, you're finding in the GU tract? How could this be? This was actually the title of a paper I did very long time ago. Okay, if you bring me the right question, I'm going to make you happy. How about that? What is a structure from the GI tract doing in the GU tract?
Urethral remnant circulation.
Don't tell me that. Go and read and come back.
Oh.
Maybe you will find my paper and answer from it, and then you will get the real actually grade. How about that? Just kidding. Okay, now chronic cystitis. The word is malakoplakia. Actually, it feels like a word from a holy book, right? Malakoplakia, like a Latin holy book. Just my 2 cents of black humor. I hope you can take it. All right. So what I'm going to tell you is that actually this is a systemic condition that could be present anywhere really in the body. So it's not really specific to the urinary bladder. It could be found in the GI. It could be found in the kidneys. It could be found actually in the lungs. The defect of this condition is with either phagocytosis or with digestion of the phagocytosed organisms. So what's going to happen is that the macrophages will be able actually to gulp in the organisms that are causing the process. Most likely it's going to be in the form of an E. coli organism, right? E. coli bacteria. But then it will not be able to complete the job by destroying this bacteria. So this bacteria is going to be internalized into the lysosomes. And what the organism will do, because it cannot kill it because of the defect in the lysosomal enzymes, it's going to start to pile on top of it a lot of heavy metals, including iron, including calcium, maybe copper, that are going actually to freeze it in time, if you will. And the end result is going to be the second German name in this lecture, known as the formation of the Michaelis-Guttman body. So these are the Michaelis-Guttman bodies. It does feel like a Mercedes, right? Mercedes or BMW or something like this. I keep saying that again and again. Right. So Michaelis-Guttman body. You see these targetoid lesions?
Yes.
Yeah.
All right. With this umbilicus in the middle. So what's the umbilicus? You go and do EM actually studies, electron microscopic studies. The center of it is actually the bullseye right here. So here actually this is the giant lysosome. In the middle of it is where the organism was, and then on top of it is this very dark structures are the heavy metals that we talked about, the iron and the calcium and everything else, surrounded by amorphous proteinaceous material right here, and that structure is Michaelis-Guttman body. This is what you're going to be seeing of malakoplakia when it arises anywhere in the body, the same exact finding. All right, now bladder obstruction, either in males as a result of prostatic enlargement, or in female as a result of prolapse of uterus with cystocele, they do the same kind of presentation. What happened now, actually, the urinary bladder is actually contracting against an obstruction, right? And it has to do that very forcefully. What happened to the muscle fibers as a result of this, intense contraction? It starts to become hypertrophic, similar to what you do when you work out. The end result is going to be hypertrophic muscular bundles known as trabeculation. Now you can see actually that, between the muscle layers, there are gaps. It is through these gaps where the herniation happened, for the development of the acquired diverticulum, right? All right, disorders of the urethra. Finally, you have the inflammation, gonococcal or non-gonococcal inflammation. What you're going to be finding is that this is going to be divided by age. Usually, younger people will have gonococcal inflammation, right? As the priorities of someone are going to shift towards the GI tract, as time goes by, then they will start to have actually GI kind of infection, and it will become non-gonococcal infections. You get that? Tumors, also the same, papillomas, FAPs, and carcinomas. And finally, urethral caruncles. These are actually masses of granulation tissue at the tip of the urethra in females that may be exquisitely painful. All right, so this is it. Any question of this lecture? Let's see how much did I do. Because tomorrow I will have probably another 10 more slides about this. Okay, good. So we finish. What time do I have you tomorrow? No.
10 a.m.
10 a.m. Really? And the girls?
11. Lot of the trabeculations, it does not involve the muscular plate.
The muscular?
The acquired cyst does not involve the muscular plate.
No, because what happened, what will herniate is the mucosa right here. The mucosa is the most deep, right? Beneath it is the muscle. Now, when it's going to herniate, because there is increased intracystic pressure, which is going to result in the muscular layers, the urothelium and the lamina propria, going through the gaps alone without the muscles. So it will result in acquired diverticulum. If you cut that diverticulum, which is really a hernia, if you cut the wall of this structure, you will not see any muscle. It will simply be only the muscle, the mucosa.
This is due to the muscle kind of connection because it's disrupted. That's why.
No, because there are gaps. There is increased pressure and there are gaps. You see, like pressure will result in this, in this mucosa giving way, and the places where it will give way is the places where there is weakness or gaps. Exactly, and that's why it will not have any muscle.